Health IQ, the courage to ask, overcoming the fear of seeking help.
Welcome to Health IQ. Today, we will be addressing a topic that keeps many people from accessing the care they need. My crew today is Bobby Hockaday and Joyce Runyon, and I am Brenda Bishop. We are so excited to have our guest today who drove all the way over from Albuquerque, even got here early so he could tour a little bit.
Absolutely.
Liam Westgate, thank you for coming. Liam is the current director at the Community and Clinical Linkages at Presbyterian Healthcare Services in New Mexico. And for those of you who remember, our hospital is a part of the Presbyterian healthcare system. You're also a social worker.
That's right.
Licensed social worker, and your bio showed a lot of interesting professional work around caring for the whole person. I thought that was interesting as I was looking at that. So today I thought we could tap into some of your work around addiction and behavioral health. But first, why don't you tell us a little bit about your role as the director of Community and Clinical Linkages?
Absolutely. Well, first of all, thank you for inviting me, and thank you for the opportunity to come to this part of New Mexico. I was really glad to be able to branch out. You know, I'm based in Albuquerque, but I really have a deep love for this state. So thank you for making me feel so welcome. So as you mentioned, I serve as the Director of Community and Clinical Linkages, which is a little bit of a mouthful. So maybe I can break that down. It's kind of full on my business card, but let's talk about what that is. So I think it really is the substance of what it is. So, you know, when we have let's say a patient that comes into a healthcare system, there's a lot of different transitions that they can go through. You know, maybe they might have a really significant health event that brings them to the emergency department, right? I always like to think about the idea that whenever someone comes to a healthcare institution, particularly in an urgent or emergent situation, that they're not having their best day. Right. So for patients that have a lot of these different transitions, we recognize that we have to build different ways to support folks with complex and differential and important needs. So our team is comprised of a bunch of different initiatives, and maybe I can talk about like 3 to 4. One, our team really oversees what's called the health-related social needs screening, which I'm sure we'll talk a little bit about screenings and how that's important. But screenings in general are a way for us to identify and anticipate potential things that are like non-medical factors that affect someone's health, right? So if somebody's struggling with houselessness, or let's say substance use concerns, or maybe they're struggling with transportation factors, right? Those are all barriers to care. So those screenings become really important. Those screenings also become a tool, so to speak, for our other 2 teams, which I'm very privileged to really be a part of and to support. One is our community health worker team, and we have community health workers all throughout the PRES system. For today, I'm going to talk a little bit about probably the central delivery side, but I also want to acknowledge that we have regional community health workers. I'm sure at some point you've connected with some of our folks, and they tend to be positioned in places like primary care offices and clinics and, you know, settings where we know folks are either getting routine or urgent care. And their job really is to make sure that if we have somebody who's there for a medical appointment, that we have a resource and a person, right, that can really address all of those factors outside of, you know, same things as before that might be affecting their healthcare, their access, or their well-being. And the community health workers on our team, they do an amazing job of that because they can have more time to spend with folks, so they're not feeling rushed. And that's just such as many of us know, really frustrating when you have a big problem and the person you're going to doesn't feel like they have a lot of time. Right. And then really the third component that feels really important to mention, especially as we talk about some of the topics today, is we also have a peer support team. And the peer support team, those are folks that have lived experience, meaning that they're folks in recovery, that their job and their expertise is really gathered from that lived experience. And our peer support specialists tend to, by and large, work in our emergency departments. So if we have somebody that comes into our emergency department, we have different mechanisms where we try to screen, again, that whole person care piece, right? And our peer support specialists, if we have somebody who is identified as needing support, let's say with recovery services or harm reduction services or just education, right? We have peer support specialists that can either meet in person, but also we have capabilities to reach and deliver, virtual care and that kind of thing, right? But one of the many things that I really respect and admire about our peers is they don't just know that kind of concern, right? They know how to get people connected. And so they're part of this larger fabric across New Mexico of folks in recovery that can kind of figure out what's the right key to the door, right? What's the right eligibility criteria. So in my role, those are probably three, bigger initiatives that we're really a part of. But again, it's part of the connecting the dots and making sure that we're helping people through those really crucial transitions.
I think that's so important. We've talked about that as an issue in other areas, not coming out of the healthcare system so much, but coming out of our detention office center and those having no linkages and our help for that. So you talked about screenings. I guess we should actually talk a little bit about our actual topic.
Sure.
As well.
This is a nice segue.
Yeah. But I think screening sort of fits all into that. But let's go ahead and say what our topic is. Our topic is stigma today and how that affects people actually accessing care. And you said that so well, and as part of your job too, is that if we have these things that barriers, but stigma is a big barrier it could be a barrier for healthcare or behavioral health care.
Definitely. We see that a lot. And it's interesting because when we talk about barriers to care, I think, if I were to ask a group, what are the biggest barriers to care? There's usually two barriers that tend to come to the top. One is costs, right? Care becomes prohibitive and those kinds of things. But what we actually find is that stigma is a bigger barrier than even that. So when we put that in perspective about, reasons why folks may not, be able to, or feel comfortable to, or feel safe enough, right? So stigma becomes such a really important thing because when you're doing this work, there's a lot of unlearning that you have to do, right? You don't always know how deep the roots of stigma might go for folks.
So then how does screening all fit into stigma?
Sure. When we talk about how screening can fit into stigma, one is that, something like a universal screening, it normalizes asking questions, right? So we're not asking questions of some folks and avoiding questions for other folks, but this idea of, you think about universal precautions, almost like washing your hands, right? Washing your hands is a universal precaution. Screening and asking those screening questions, there's really two pieces of that. One is that not only we're making sure that we're asking questions that maybe folks wouldn't otherwise share information, but when we screen, we also have to make sure to teach folks how to ask those questions, right? How do I do that in a compassionate way? How do I make sure that there's no paraverbal communication or facial expressions or other forms of communication that are running contrary to asking those questions? And what's really interesting is when we train, even sometimes when I've trained social workers, sometimes folks are like, I'm afraid to ask that question, and we dig into that why, right? Well, what if I create a new problem, right? And what we actually find is that asking those questions doesn't necessarily create new problems. Sometimes it's a relief for folks that people asked, right? And it opens up a conversation, right? Whenever we screen, the goal is not to do a certain thing or mandate a certain type of outcome, but just to open a conversation. And, if anything changes, if you need anything down the road, just know that we're here, right? So that's when I think about that, it's a conversation starter.
Okay. So you said stigma is a barrier, but maybe we should define stigma a little bit better.
Sure. That's a good thing. So when we talk about stigma, if you look at sort of the root word of stigma really in its one of its original translations, it means a mark of separateness. That's really what stigma is. So if you have a mark of separateness, one of the ways that can show up is sometimes it can show up in terms of exclusion from the group. Sometimes it can show up in terms of the stories that people tell about someone who is being stigmatized, right? So not only is it a mark of separateness, but what we find sometimes in mental health is that stigma can also be a mental health burden, right? If I feel stigmatized, it's gonna, not just create a barrier for me to get help, but it's also gonna make me feel more likely, right, to have a really compromised self-view of myself, right? So there's a concept called the cycle of stigma, right? And that internalization of stigma is really what we see that can really affect mental health. So it can be a relational thing, right, in terms of that separateness, an in-group or out-group, but it can also be something that we bring inside of ourselves, right? And it becomes a story sometimes that we might tell about ourselves.
So our belief of ourselves.
Exactly.
Our belief that sometimes maybe we're believing that other people are thinking something that they're not thinking.
That's exactly right too. That's actually another, when we talk about all the different barriers, right? So you identified something so spot on, which is sometimes stigma can turn into both the stories we tell about ourselves and what we start to anticipate from other folks. So if I've met a lot of folks that have stigmatized me, the likelihood of me expecting new people that I meet, right? This is not a real diagnosis, but it's a social diagnosis in my mind, but I think of it as anticipatory anxiety, right?
That makes sense, and we have that a lot of times with not just, going to care, but just, anticipating a test or whatever.
Yeah, just anticipating an outcome. And in psychology, sometimes we talk about that as catastrophizing or time traveling, right? Imagining future events that are not quite there yet, not quite real yet. So there's lots of different ways that stigma can show up.
And so that impacts, of course, their health care because they're not going, but it does also impact the care that they're getting because maybe they're not communicating as they probably should because they're afraid to say things.
Yeah, that can certainly show up. One of the ways we might articulate that or see that is when we work with folks where we as providers sometimes know there's maybe a deeper story that's going on, but maybe because of what somebody's experienced, right, they might be really guarded, right? So if I saw this a lot when I worked at Bedside before I worked at Presbyterian, where sometimes we'd meet with folks where it had to be really bad before somebody was coming into the hospital because of all these experiences that they had before. So sometimes you can see that the guardedness, sometimes the real fear or concern about sharing that deeper story, right? But that definitely, that self-protectiveness, which is justified, right, can definitely show up in help-seeking behaviors.
Yeah. I've never been a person who's good about sharing my feelings, even with the people closest to me. And so to me, that whole thing about having to share what I feel is scary.
It is.
So I can see that being a barrier as well.
100%.
So we're talking about, how we could support those people. Are there things we could do in our community? Are there things we can do as a institution, maybe not just Presbyterian, but some of our providers that would help reduce stigma?
Yeah, I think, one of the things you just did, and maybe you don't realize you did it, but you just said, I experienced this, right? And sometimes that idea of opening a conversation through courageous sharing really matters, right? If we are spending a lot of time writing stories about ourselves, we're sometimes doing that with other folks. So I think some of the mental health efforts around sharing your story, sharing your recovery story, or just normalizing that feelings are scary, right? I think something like that is really, really valuable. I think, before I moved to New Mexico, my family actually is from a very, very small town, right? Not actually a little bit smaller than where we are right now, just for context. So when I was driving here, I was also thinking, like we were talking about before we started today, what does it look like when you live in a small community and people are seeing your experience?
Right.
Right. And I think there are also a lot of strengths in smaller communities, right? Sometimes because we know each other, we also have the power to bring people close when they're struggling and not, make people feel like they're at arm's length, right? If we see somebody who is seeking help, that's a really good time to cheer them on, right? I think the other thing, especially when we talk about addiction, we always hope that it's a straight line towards recovery, but people do relapse, right? And that's a part of the process. And I think about one thing that can really reduce stigma is not only to bring that person close when they're struggling, but also to reflect that, we may have stumbled, but we actually haven't lost ground, right? That person still has done a lot of learning and they are trying, right? So I think that one of the biggest ways to counter stigma is connection.
So you said a couple things that popped in my head now, but as we look at harm reduction, there's a lot of stigma around harm reduction.
Yes.
And you were, and you were talking about that stumble, but even getting started by protecting yourself, taking care of yourself. But I think there's a lot of people don't want to be seen getting the help like that.
Yeah. Yeah. It's, I think everybody in this current moment, right, we've inherited a lot of very really enduring approaches and thoughts about what addiction is and what it's not, right? And, for most of human history, addiction, for instance, has been treated as a moral failing, right?
Right.
When we actually see that it doesn't quite work that way. It's not really a choice, right? What we actually find is that, and thinking about harm reduction, this is another connection, is that the more, again, connection and protective factors that we can put around that person, think of it almost like a spring, right? If I can create that coil under someone's foot, right, around keeping them safe, then I can help them spring to a better place of recovery. But harm reduction is often, there is a lot of stigma, like you were saying, around harm reduction. Harm reduction is sometimes seen as just a different form of using substances, right? Whereas, when we talk about harm reduction, it's really about keeping folks safe while they're building their readiness to change. One thing that a lot of folks don't realize, or sometimes unless you're in that experience, when you're struggling with addiction, when you stop, you actually lose a lot. You might lose friends. You may not be able to go to the same places you were before. So when people are making that change, they're also taking sometimes a really big risk to go into an environment that's a lot of unknown, right? But harm reduction is a way to sort of make that process a little bit smoother, so it's not always as drastic, right, as it could be otherwise.
So you were also talking about it's not a choice. And I think that's interesting. Maybe initially is it a choice, but is addiction always not a choice?
Well, I think there's a distinction between use and addiction.
Oh, okay.
Right. So, we could look at, this is where it gets fuzzy, right? It could be choice for initial use. However, we don't often know how a particular substance might affect us, right? And it's actually way more complicated when you actually look at that. But the things that we actually find that can really, really sometimes, not always, but sometimes can really accelerate into problematic use is just really serious stress. If somebody's, maybe they have family stress, maybe they have job stress, maybe one thing that comes up a lot is grief. If you've lost somebody and you feel that isolation, that, there's a lot of different, being human is a very fragile experience, right? And most of the things that happen to us, we don't often plan. So sometimes also a life event like grief or loss of a spouse or a parent, right? That can put us in a really lonely place that would bring us out of character, right? So whenever we talk about, in treatment, really understanding that person's story and that journey is really important, right? And more often than not, when I've worked with folks, it's been those really defining life moments, like I lost my wife of 20 years, or I was a caretaker for my parent. Now what do I do? Right. And those things can also really shape us.
Okay. So way back, you also talked about we should cheer people on for getting care. What would be appropriate ways to cheer someone on?
Yeah.
Because I could think that we say, oh, good
Yeah,
job.
yeah, yeah, yeah,
and
yeah.
that's sort of demeaning.
Yeah. That's a really good question because we don't want to be like a rescuer, right? But, different ways that we might do that is, hey, does this person need a ride to treatment? Let me give you a ride. Does this person need a meal? Let's have some normal, right? Maybe it's also like, a quiet comment. I see what you're doing. I see the changes that you make. I just want to let you know I'm here with you, right? When I think about cheering those folks on, I think about that idea of being with and coming alongside, right? When we talk, I know before we started today, you were talking about motivational interviewing. And if you learn about motivational interviewing, everybody gets excited around action.
Right.
Everybody gets excited around action. And that's actually sometimes the most vulnerable moment for folks because they're making a big change. So that's actually a really great time to like come alongside so that person's not making that right turn into a new life by themselves.
Okay. So just quiet things that seeing what they might need and saying, hey, I'm here to help you.
Yeah.
I'm here if you need anything.
You can also just ask the person, just be like, I want to be honest with you. I'm super excited about the changes in your life. How do you need me to support you? Right?
Oh, yeah.
Yeah. How
That's
do
a good way.
you need me to do that? Do you need me to be high-fiving you every day? Do you need me to text you in the morning? Right? Do you need me to help distract you in the evening when you might be at a moment, right? That's another thing we can also just reach out. How do you want me to show up? Maybe tell me 1 or 2 ways I can do that.
Oh, that could be powerful. I like that. Cool. So we're sort of running towards the end of our time. Is there anything else we need to make sure we hit on that around this topic that we didn't cover?
I think you asked some really good questions. And I also think that, I think a lot, again, I think just to emphasize the business of, community and connection are the most important protective factors. We actually find in psychology and social work and practice that the more that someone can be connected, that sense of connection can actually sometimes be more motivating than the feelings that can come up related to addiction. So when we talk about this idea of prevention and what other folks can think about connection as your superpower, right? Think about connection as your superpower. But I'm really just glad we could, again, kind of similar to our universal screen, open up the conversation and just give little points to be curious and thoughtful about.
Yes, that's wonderful. So we would like to thank you for coming today. And I knocked it over, but we have a gift for you.
Thank you so
Appreciate
much.
you driving over here, and I'll give you one of our Health IQ tumblers.
I like it. I can bring that home and tell my wife I have a Health IQ. So that's
And if you are in need of resources for a person to talk to, please refer to the Quay County Health Council's website at qchealthcouncil.org and click on a resource directory. And we have the mental or behavioral health, and then there'll be lots of resources for you there. And we want to thank you all for joining us today, and be sure to come back next time as we have another topic that will be important to the health of your family.
Special thanks to our guest contributor this episode, Liam Westgate, Director, Community and Clinical Linkages, Presbyterian Healthcare Services, New Mexico. Our host was Brenda Bishop. Before we go, let's give a huge shout out to the masterminds behind the scenes. This whole production was directed by Robert F. Hockaday, who also wore a ton of hats as producer and the one-man band for all things video and audio.
Joyce Runyon also jumped in as a producer, video and audio wizard, and even snagged the second assistant camera spot. And when it was time to make it all look perfect, our awesome editors were Robert F. Hockaday and Joyce Runyon. Seriously, give them a round of applause.
Funding for this podcast is provided by New Mexico Legislative Appropriation from Representative Jack Chatfield. Brought to you by Quay County Health Council. Follow us on YouTube, Facebook, and Instagram at Quay County Health. If you have content ideas, reach out to us at healthiqpodcast@gmail.com.
This podcast was created solely for educational and entertainment purposes. It is not intended as a substitute for advice from a healthcare or mental health professional.